Hello, I'm Dr. Joshua Richter. I'm Associate Professor of Medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai, and the Director of Myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. Today, I will be discussing the risk factors for infections in multiple myeloma, as well as prophylaxis and potential management strategies as patients are treated with anti-multiple myeloma therapies. Multiple myeloma is associated with immune suppression and immune dysregulation that impacts a patient's defense against pathogens, thus increasing the risk of infections. Infections are the leading cause of morbidity and mortality in patients with multiple myeloma. Certain patients with multiple myeloma may be at greater risk of infections. Clinical factors that can influence the severity of infections in multiple myeloma can be patient-related and/or treatment-related. Some patient-related factors include age greater than or equal to 65 years, male sex, neutropenia, elevated serum lactate dehydrogenase levels, pathogen exposure history, high tumor burden, disease stage, immune cell dysfunctions such as B cells and natural killer cells, and comorbidities such as renal dysfunction. Treatment-related risk factors include lines of therapy, therapy type, antigen target, regimen combinations, and treatment intensity such as cycles and dosage. Specifically, anti-multiple myeloma treatments result in cumulative immunodeficiencies that may increase the risk of infections. Treatments that may increase infection risk include stem cell transplant, chemotherapy, glucocorticoids, immunomodulators, checkpoint inhibitors, small molecule inhibitors, antibody drug conjugates, and T-cell engaging therapies such as bispecific antibodies and CAR T therapy. In particular, anti-multiple myeloma therapies that target the B-cell compartment are associated with high-grade infections, including grade 3 or higher infections. Of note, checkpoint inhibitors are currently under investigation and currently not approved for the treatment of multiple myeloma. Additionally, the only approved HDAC inhibitors and antibody drug conjugates have been taken off the market. Of note, T-cell engaging therapies are associated with adverse events, including cytopenias and hypogammaglobulinemia that increase infection risk. T-cell engaging therapies are also associated with cytokine release syndrome, the symptoms of which may mimic those seen with infection, including fever, tachycardia, and hypotension. Common types of infection in patients with multiple myeloma include viruses, as shown here, including HBV, cytomegalovirus, herpes zoster, and respiratory viruses such as influenza and COVID-19, but also gram-positive and gram-negative bacteria and fungal infections, among others. HCV is a slightly less common viral infection, with some occurrences noted in the literature. Given the increased risk of infection, multiple organizations have compiled recommendations for the management of patients with cancer, including the NCCN and IMWG. For patients with multiple myeloma, consider prophylactic measures, such as updating a patient's immunization status, including seasonal influenza, COVID-19, pneumonia, and shingles vaccinations, risk-adapted antimicrobials, immune globulin replacement for management of hypogammaglobulinemia, and patient education to avoid pathogen exposure. Of note, immunosuppressed patients may have diminished vaccine responses and increased risk of viral shedding, for example in COVID-19. Additionally, the recommendation to use monoclonal antibodies in the treatment of COVID-19 may change as new variants and vaccine treatments emerge. In addition to prophylaxis, consider infection diagnosis testing for presence of fever, as well as laboratory and imaging screenings such as complete blood panels and CT scans. It is important to recognize clinical signs that are similar between infections and CRS, such as fever. Therefore, appropriate differential diagnosis should be considered for diagnosis and management of infections. To manage infections in patients with multiple myeloma, consider administration of antimicrobials. As always, it is important to consider drug interactions when managing infections in patients undergoing anti-multiple myeloma treatments, as these treatments and infection management agents can both be substrates of metabolizing enzymes resulting in altered drug activity. For example, CYP450 competitors and inducers. In addition to management of active infections in patients with cancer, the International Myeloma Working Group also provides guidelines for risk-adapted antimicrobial prophylaxis. Younger patients with low tumor burden and reduced comorbidity risk, or who have received fewer previous lines of therapy, may be at a lower risk for infection and may not require prophylactic treatment unless patients have had prior herpes simplex virus episode, in which case can use prophylactic acyclovir. Updating vaccination status should also be considered in prophylactic care of low-risk patients. Additional prophylactic care may be considered for older patients between the ages of 55 and 70, or those who have had other risk factors including moderate renal dysfunction, significant myeloma burden, first myeloma relapse, and mild to moderate cumulative immunosuppression such as hypogammaglobulinemia, which can be managed with intravenous immune globulins. Although infusion of immune globulins are frequently well tolerated, consider standard premedication to reduce the risk of infusion-related reactions. Intravenous immune globulins can also be used as prophylactic care. In these patients with intermediate risk, levofloxacin may be administered for bacterial prophylaxis, and myeloid growth factor support can be considered for patients at risk of neutropenia and/or with chronic neutropenia. Patients with severe mucositis and prolonged neutropenia may be at greater risk of fungal infections and may be treated with fluconazole or micafungin. Patients who are seropositive for herpes simplex virus or herpes zoster virus should receive acyclovir or valacyclovir for viral prevention. Updating vaccination status should also be considered in prophylactic care of intermediate risk patients. Finally, patients over the age of 70 or those with an ECOG greater than or equal to 2, severe renal dysfunction, high myeloma burden, relapse refractory disease, or severe cumulative immune suppression may require more aggressive prophylactic care, including bacterial prophylaxis, as well as intravenous immune globulins for hypogammaglobulinemia management. Updating vaccination status should also be considered in the prophylactic care of high-risk patients. For patients with severe mucositis and prolonged neutropenia, consider fungal prophylaxis, including micafungin or azoles, as well as prophylaxis against pneumocystis jirovecii pneumonia as clinically indicated. Viral prophylaxis guidelines for patients who are seropositive for herpes simplex virus or herpes zoster virus follow the same guidance for intermediate risk patients. While prophylaxis for patients who are seropositive for HBV should consider the risk of reactivation, including HBV serostatus and type and duration of immunosuppressive therapies. These patients should be managed with risk-adapted antivirals. To learn more about characterization and general management of adverse events associated with anti-multiple myeloma treatments, please visit janssenscience.com.